So welcome everybody to our group board in public for Bristol NHS Group. Here we are today at the For All Healthy Living Centre, which is in one of our really important and very resourceful communities here in Weston-super-Mare. I think it's particularly fitting that we're here today in the wake of the publication of the 10-year plan, with its emphasis on neighbourhood health centres, because that is exactly where we are today. This is a community interest company owned by local people, which provides GP services, social services, children's centre, all kinds of multi-agency initiatives, but also coffee shop, a community centre for local people to use. And it's very much a trusted space for the communities around here. So I think it's really great that we happen to be here today for our meeting in common in the wake of that 10-year plan. And I'm really proud also that we're part of this story. We've got the Community Diagnostic Centre right next door, actually on land that is owned by the For All Healthy Living Centre. So it's evidence of our partnership with them. Okay, I only have one apology for absence, which is from Anne Tutt. And welcome to colleagues who've joined us, particularly one of our governors, John Rose, who is a public governor for Weston, actually. So welcome, John.
Thank you. Apologies from Jane as well. Jane.
Oh, we also have apologies from Jane Kawaja. Sorry, I didn't know. Any declarations of interest today?
Just to say, I've been recently appointed as a non-exec director on the Sunset Foundation board, which I've formally led.
Okay, thank you. And that's gone live now, has it?
From the 1st of July.
Okay, so congratulations to Rosie. And Rosie, that means this is your last board with us, as it is for Kelvin, actually, who has also reached the end of his term after many years of service to both trusts. So should acknowledge that too. And also that not with us, again, because she reached the end of her term, is Susan Hamilton, who finished her term at the end of last month. So just to acknowledge that and thank you for everything that you've done.
And see?
So it's yours, isn't it? Okay, so any declarations of interest? No? Okie-doke. In which case we will move over to hear from Melanie about your story with Arthur. Matthew, do you want to kick us off?
Thank you, Ingrid. Hello, board members. Really delighted to be here. I'm Matthew Ariscook. I'm the Head of Experience of Care and Inclusion at UHBW. And I'll keep this short and sweet because you're not here to hear from me, you're here to hear from Melanie. Also, just to introduce Amy Vafai, who's one of Arthur's consultants. And just reflecting on the amazing ITV News special that was put out from the Children's Hospital, filmed last week, just about the importance of our care for children, young people and families. And one of the real privileges in the role that I'm in is I get to meet with the very people that we're here to support, patients, community members. And it's been such a pleasure to meet with Melanie over the last few weeks to really reflect on, and what I think Melanie's going to be sharing a bit about today, is the importance of the quality of the relationships between the people that we support and the people providing that care. And that's all I'm going to say, and I'll hand over to Melanie. Thank you very much for coming along.
Okay. I'm not sure my voice will be loud enough. Hopefully you can hear me. I thought I'd just give you a really quick summary of Arthur so you understand what his needs are, and then I can talk about how that's been met by the hospitals. So Arthur, as you met him, is really sociable, cheeky, happy little boy. He's lovely. He's 10, but he has quite a lot to contend with in terms of his health, and he spends a huge amount of time in hospital and has done all of his life. And I think, we were just talking about it earlier, I think that's very different than somebody that comes into hospital on an occasion and then they sort of see the service and then they go. That is one thing. But I think for families like ours that are just constantly, it's a lifestyle, it's part, the people that he meets are he sees as his friends because he sees them all the time. He spends more time with them than maybe he does with his actual friends at school and things like that. I think it like takes on a different meaning in a way for us as a family and for him. So when Arthur was born, I didn't know that there was any complications when I was pregnant. And then as soon as they lifted him out, had a cesarean, as soon as they lifted him out, he made a funny noise and that was it. They sort of took him off. So we knew right from the start that things weren't okay, but we hadn't known previously. And to begin with, we were in the NICU for a while, and I think they thought he was ill to begin with, but then it turned out that he wasn't ill. He just had these sort of medical problems. And to begin with, he was diagnosed within 2 weeks, which is amazing because I've been on a lot of websites of families that have his diagnosis, and it seems like Bristol has been very, very good in terms. We've been very pleased with all the consultants and the care that he's had. We feel like we got diagnoses really quickly. We found like all the tests. I've got friends that I work in the NHS as well. So I have friends that work in all different places in the NHS, and I think everybody was quite surprised at how quickly everything was done and how well it was done. So that was a really good experience of being in NICU, and then we were trained up to take him home. So originally he had Worcester-Drought syndrome, which is cerebral palsy that's predominantly here. So he also has it everywhere, so his mobility and everything is affected. But here to here, we were told that he wouldn't ever eat or drink, he wouldn't ever talk. We were actually told he wouldn't ever smile, which is literally the opposite. He doesn't stop smiling, which is nice. But the other things were true. So anything to do with kind of this area, that's not going to happen for him. And I think as he went on, he probably did a lot better than people thought he would. And he was doing really, really well till he was 4.5. I pushed for him to go into a mainstream school because I felt that he could manage that. He started in reception, but then unfortunately, from the area of the brain that you can see to do with Worcester-Drought, it has formed problematically. He started to get epilepsy from that. So it's not unrelated. It's like he has two things, but they are related. And he has Lennox-Gastaut, which is a really difficult type of epilepsy to manage. And the intricacies of the two things together makes him really, really vulnerable. So he's already got problems here. He also had a bilateral vocal cord palsy as well into the bug, and so it's all this area. And then when he has seizures, it affects his airway as well. So he's really, really high need. And that was quite sad for us as a family because he'd been doing so well. And although we'd been in hospital a lot, it wasn't loads at that point. So then from 4.5, we've just been in all the time. Because his epilepsy, in about 6 months, he went to being in a non-convulsive status constantly. So it was a really, really quick sort of onset of everything. And it was COVID as well. So there was no surgery available. It was all just a bit of a nightmare, really. So I was in hospital on my own with him because no one could visit. And that was kind of a big sort of start of being in hospital all the time. As soon as the theatres opened, we did have a corpus callosotomy, which is like brain surgery across separating the two parts of the brain. And it is just a bit of a journey of everything helps for a while and then it doesn't. And that's just where we are. He's deteriorated cognitively. So when he started in reception, he was sort of slightly below average, but within his year group. Now he's functioning at about 2 or 3 and he's 10. So it's kind of those things like throwing away toys and getting new ones, but they're younger. That's quite hard. Mm-hmm. Sorry, I wasn't going to cry. There's lots of things that have been really difficult for him and for us. And another thing that's difficult, get the difficult things out of the way. Another thing that was difficult is last year he was put on an end-of-life pathway, which was really difficult for us all. And we were told that there was pretty much no chance that he'd be taken off the ventilators. And we agreed to him being sedated really heavily, more than you would if you were looking to bring him back. And so we went through, we had all our photos done and we did the whole thing, but he did actually survive, which is wonderful. And here he is. So we've had some really, really difficult things as a family to go through. And one of the reasons that it's kind of been okay is because he's such a joy and he's always full of fun and he's just a beautiful child and somehow is massively resilient to all of it. But the other one is that we just feel that we have had a really excellent service from the hospitals, from Bristol Children's Hospital and the Seashore Centre. And I kind of know when I was asked to do it, they were like, let's hear the good things and the bad things. But I do feel that we haven't really had many bad things. I know there's other families that might have had, but I can only say from my experience that we feel that we have had the best care at all times. And I feel that through some of these really difficult times, like when he was deteriorating, like when we were waiting for surgery, but there was no surgery happening, the whole end of life where we were in PICU, I just feel like personally, and I say we because two of my children are adults as well. So, and I have another child that isn't. I think we just always feel quite overwhelmingly that we're so supported that actually the relationships that we have with people do buoy us up. They do keep us going. We don't feel alone. It's quite surprising. Sometimes when you're in a really high need situation, like you're in PICU, which we're in PICU quite a lot, it's like people still do have time to have those personal conversations with you. People do always tell me what's happening. They always take the time to explain to me why. I'm always in a position where I have some choice about things. I tend to go with medical advice because they know more than I do, but I'm always consulted. I don't ever feel like things are out of my hand or I don't understand them. I think I don't know what other people come to say, but I just really want to come and say how great things have been really and how grateful as a family we are. And I think sometimes you can focus, I work in services as well, and I think sometimes you can focus on complaints and think, well, we need to change things, we need to do things because that hasn't gone well. But then sometimes what you miss is what we're doing well, actually. And so sometimes you can change those things to go towards what's gone wrong. And you forget actually those are the things that all the happy people, all the good things that are happening. I think it's really important that maybe I was quite pleased to come here because I think people tend to speak up when they're not happy, which is understandable. But sometimes it's nice to feedback at what goes well. And I think one of the things at Weston in the Seashore Centre and in Bristol is the quality of the staff that you have, actually, the people that you have there. And I think that because you manage to maintain staff and retain them for so long, it means that families are able to make really lasting, trusting relationships with people. And the consultants that we've had, I mean, epilepsy sort of neurology wise, so he's 10, basically had one person, then she retired and we had her trainee who still kept in touch with her. Then she came back and we were asked. And so it's so brilliant because I feel like they totally get him. So all my concerns, all the things that I say, I just know that they know him inside out. When I go on holiday, which invariably I do, and we end up in hospital, don't we, pretty much, as that's what we do on holiday. It's really noticeable because people don't know us. They don't know what to do. They don't look for the signs. And I'm there sort of saying, and it is very stressful, actually, to be with someone that's so vulnerable and people don't get it. And I think the fact that staff stay so long in Bristol and in Weston, and you can really get to know them, it just makes it, for me, it's reassuring. So just as a parent, it's just lovely because I have absolute trust. If Arthur does something, I just think, oh, we'll phone them, they'll know what to do. But also I think for Arthur, I genuinely don't think he would still be here if it wasn't for those people, because he's very complex and it's really easy to miss things. And there are times, like there's one time I was going to talk about recently where I went into the Seashore Centre and people know me really well there. They know Arthur really well. And they know things about him aren't necessarily routine. So I went in and I knew that he wasn't okay, but I couldn't tell you why. I got up one morning, he was fine the day before, and I just looked at him and just the way he was, I just felt like he was having lots of seizures, but I couldn't really film them because there wasn't enough to see. But I just wasn't, everything that he did, I was like, he's definitely not okay. I feel out of my depth. So I took him down to the Seashore Centre and he literally looked fine, and they did all the tests and he came back fine, didn't he, on everything. So, and then he just decided to not even do the bits I was worried about and started playing with all the staff. So I was like, no, honestly, I have been in experiences with that, even in Bristol Children's, to be honest, when it's people I don't know. That's more rare these days, and they'll sort of say, well, we haven't got any reason to keep him in, and so they'll all send him home. Whereas there, because they know him and they know me, they were like, he seems fine and we can't see any problem, but also we know you and we know that often you're right. And actually, I don't come in all the time. And when I do come in, it normally is right. So they kept him in and he kept playing and being fine for like about an hour. I was thinking, oh, it's a bit embarrassing. I'm really sure he's not okay. And then he got really, really ill while we were still there. And then he did end up in intensive care in Cardiff. So it got to a point where they had to call the crash team and it was all very intense. And I just think if I don't have those relationships with people, if they don't know me, if they don't know Arthur, those kind of things will go very badly wrong. If I was at home and he deteriorated like that, the ambulance wouldn't have come for ages because that's always a thing. Then when they came, they wouldn't have necessarily been paediatric trained. Like there's lots of problems with being at home. And I wouldn't have took him to Bristol because I would know that there was nothing that they would keep in A&E for. So going to the seashore is kind of like a step down where I can just go, he's not okay, can't really explain it, probably not going to take him to A&E right now, but can we just like look at this together? And that's just so helpful to have that. And I do think that things could have gone very much the other way had that not happened. And I think Amy is particularly good because she's seen him, as my two consultants are absolutely brilliant as well. They've seen him so well and they've seen him so ill and they've seen all of it. And I think unless you have seen somebody like Arthur in all of his sort of fullness, you can't grasp it. It's like one we were joking at there, but it's not really a joke. So he's always really cheeky to the point where when they extubated him after he was on the end of life pathway, so they were bringing him back from being really heavily sedated, the first thing that he said was he kind of could minimally move. So he just pointed at his sister and basically said she was a monkey because he was so cheeky. The first thing that he did when he came back was just insult his sister because that is what he's like. And then he sort of said all the nice things that he loved us and things, which was lovely. But he's quite deceptive. So if you don't know him and he comes into A&E in, say, a different town, and you sort of look at him and think, well, he can't be that bad because he's still joking about and he's still got a beaming smile on his face. He will never not. Even in that awful end of life scenario, when they were going to put a tube down, he was still smiling at them. And even the doctor was like, it feels really difficult to do this because he's smiling at me, but also I know it's the right. We talked to the hospice for hours. We'd sort of gone through, he had an end of life plan. So I think, it's just so reassuring for me and so good for Arthur that he has people around him that really know him well. One of the problems, again, is secretions, which Amy knows. So on his notes, it will say really clearly he has thick secretions. That doesn't give you any information because his secretions are so madly thick that even when people read it and they're a doctor that deals with that, they're like, oh my gosh, this is ridiculous. They are so thick. They're like melted cheese and you cannot move them. And what happens is if I come into A&E in Weston, I see Amy there, I'm like, oh, it's going to be fine. Literally, I feel like that. I can feel really upset and tearful and what's going to happen. And then I see someone, I think it's going to be fine. Because she will know immediately, she won't go through step 1, step 2, step 3, which of course you have to do with everybody. You have to go for the least, don't you? That's how it works and that's the right thing to do. But someone with Arthur, because you know his history, because you know his flexibility and sort of like he'll suddenly drop off a cliff, you can just go, this is actually Arthur. We're gonna bypass step 1 and 2 because we're gonna really get into trouble if we don't. And it is so, I just think that's the reason Arthur's here, because he has such good care. Yeah, and there's other things great, like I could go through so many times where we've had great care, but we don't have the time. But I just think the main thing is all of them come back to that same thing of having 2 really good consultants, because mainly neurology and respiratory are our 2, and they're just fabulous. They'll like speak to me if they're not meant to be in call, if they're in another hospital or something, they will be contactable. And so I've always got those people to say to people, sometimes I feel in hospital, even now, someone might come in and they might say, we're going to do this. And I'm thinking, oh, really? I'm not sure that's the right thing. And I'll say to them, can you just ring his own consultant? And it's just brilliant because they always will. They'll always take the call and then he'll just get the right treatment straight away. It's that sort of trial and error is gone. So I don't know if that's enough to say, but yeah, I just think it's really important that everybody knows what brilliant team you've got and how lovely it is as a family to be held by that.
Thank you, Melanie.
Oh.
It's really humbling, isn't it, to hear Melanie's story and Melanie, the impact of your, you know, the emotional and other demands that you face day in and day out. Absolute respect to you, you know, amazing. I'm sure you get huge amounts of joy as well. But thank you, and just a thank you and acknowledgement to Amy and to Beth for the brilliant clinical services that you've been overseeing. And the importance also has come through about, yes, the specialist stuff in Bristol, but actually the local thing here at Seashore Centre in Weston as well. It's the combination of both that has been really important, isn't it?
There's another really quick thing, if you don't mind, just a really quick thing, just that you've reminded me. Another really good thing about Weston is that, because I'm a single parent, it's really difficult for my other children when I'm in hospital. So we've now developed a new plan that because he needs IV antibiotics, he doesn't have oral ones and it is just straight to IV now. It means that now I can be at home with my other children at night because I can stay at home and I can go into the seashore every day. And it just means I haven't got to farm my children out and find people to have them all the time. Whereas when I'm in hospital, like, it's really difficult actually to find people to constantly have my other children. So again, that's the local thing that's so good.
Any thoughts, Paige, you want to follow through? Rosie?
Hi, Melanie. Thank you very much for sharing your story. I think the two really powerful things that came through from what you've said to me, other than you're an amazing mum and you're having to, you know, what you're doing is amazing, and I'm really pleased you had good care. But two of the things that came through were firstly the continuity of care and how important that's been in your journey. And I think actually when we're looking at the clinical strategy and the work that happens here, how do we really think about continuity of care for people, particularly with long-term conditions and complex needs? And I think the other thing that came through was the real importance of listening to parents and listening to patients and listening to their experience. And I work in patient safety in my other job, and actually what we hear all of the time is where people don't listen to people and don't listen to their feelings about what's wrong and don't listen to their concerns, and then things don't end up so well. So it's really good to hear that you feel that you're listened to, and when you are worried about something, that's taken seriously, because that's so important.
Yeah, I think that's the case now. I don't think that was always the case at the beginning. I did have one in particular experience where I wasn't listened to and I kept getting discharged from a service. That was a respiratory service. It wasn't my consultant. And I even got a letter saying, Mum says this, but our sleep study shows this, which felt a bit like, okay. I found that quite intimidating. So I backed down. And I think it's easy to forget that doctors hold a lot of power. And actually it's very intimidating as a parent to feel that that's how it's being seen. And then when I went back to the community paediatrician and said, we don't go anymore, and she was alarmed and like, oh my goodness, why not? You've been managing this at home. This isn't okay. And that's when I got put in touch with the respiratory team I have now, who are brilliant. Yeah, that just shows the difference, doesn't it? When it's just someone, they do a tested one overnight sleep study and it's like, I don't think so. And it is really powerful actually telling people that essentially you don't believe them, maybe. That's how it felt. And yeah, the continuity care is the way away from that, isn't it? Because they get to know you and more than just one study.
So I can see Paula and Kelvin want to come in, and then I think we do need to wrap up. We can love to spend all morning in conversation with you, Melanie. We do actually have some other stuff we need to be doing, but let's go to Paula.
Hi, Melanie. Thanks so much. That was just an inspiring story. And having worked more intensively myself at Weston for a few years now, I'm just delighted that you've drawn out the importance of that link, because for me, having that ability to link up the really specialist skills that exist in the Children's Hospital in Bristol, but make that available locally and provide that shared expertise. You know, you've articulated that so perfectly today, you know, and I feel really passionately that that is what should be available, because for me, that is about, you know, local care, but with the very best of care available locally, not second best. So you brought that through, and I think that the team at the Seashore Centre are just so passionate about expanding their services at the Seashore to other specialist and kind of provision. And so I know they'll be highly chuffed by the feedback that you've given them, and sort of give them that real sense that they are doing the right thing. But please spread the good words that were shared with us today as well, because sometimes I think we need to build a reputation of Weston Hospital and very widely. So if you get a chance, keep doing that. Thank you.
Thank you. Thank you, Paula and Kelvin.
Well, I think I've got the best seat in the house, actually. Yeah.
Next door.
What an amazing mum you are. And for advocating for your son and doing it so well. I think my question isn't for you, it's for us. And it's about how we make sure we give that the experience for every young child in our care going forward, especially with complex needs, that we give the same provision of healthcare that we give for Arthur to every young child moving forward. And I think that's my gift for you today. My last meeting is to say, challenge us to ensure that we continue that journey, and we ensure we spread that word to every clinician in our organisation, that they're allowed to establish really strong and lasting relationships with individuals, the ability to be personable. In my experience with disabled individual in and out of hospital, it's those relationships that have kept me buoyant and healthy. So it's fantastic. So thank you. You're an inspiration and a brilliant mum, and I think it's been a massive pleasure to have you here today, and the challenge is on us.
So, Melanie, thank you. Thank you for coming to share your experience with us. You are amazing. Others have said it, but, you know, as a mum to a mum, you're brilliant. And thank you to Arthur. It was great to meet him. I saw him. There's a little glass door behind you, and I've seen him hopping about, playing the clown out there. So a very happy boy. And, oh, there he is again. So thank you for coming and for sharing with us. I think it's a time of change for us. There's a lot of change in our services, and some of the important messages that you've given us and that others have reflected on about listening, about continuity, about relationships. Really take that on board. So thank you. Thank you so much for what you've got. It's really got to move on from that to something like minutes, isn't it? But that's where we're going next. So please can we turn our mind to the minutes from 13th of May meeting, which was again a board meeting for the whole group. Any amendments to those minutes? No? Okay. There are just a couple of matters arising, both of which are ongoing. So the no criteria to reside item on the board assurance framework will be reported to board in September, and similarly the board work plan and committee terms of reference will be coming to us in September. Are there any other matters arising that people have noticed in those minutes? Okay, thank you, in which case we'll accept them as a fair record. We don't have any written questions from members of the public, and I've only got you here, John. So, only in the sense of single John. Yeah. Okay, so we'll move on from that item as well to the chair's report, which covers the time from our last meeting in the middle of May up until the end of June. So as usual, you'll see I've been undertaking a range of visits to both trusts, different services. I would just pull out the the visit to St Michael's, which I know we will be speaking about later, but I wanted to go personally to St Michael's in the wake of the fire. I know others have as well. To say thank you to people there for the absolutely amazing response that they gave in getting that under control, keeping everyone safe, and getting back to business as usual as quickly as they did. It was remarkable. So just to highlight that particular visit. We also had the Full Hearted Care Awards for UHBW colleagues, and I know some of you were there. Some amazing stories about brilliant work being undertaken by colleagues right across our trust. So it was really good to be there at Ashton Gate Stadium, getting to walk through the tunnel. Felt quite good. Lots of visits to partners ongoing as well. I would highlight the joint visits that I'm doing with colleague chairs. So most recently, the chair of Sirona and I undertook a joint visit around various spa services at MBT. I'm due to go with her to visit some services at Sirona, and then she'll be coming to UHBW later. But it was very evident that, you know, we all know the interface, don't we, all too well, between our two services. And it's really important that each of us sees for ourselves and personally exactly what those interfaces are like, where it works well and where we do need to do things differently to improve. So that was useful. I'd also highlight a couple of other external visits, particularly the Maggie's event. So Maggie's is a charity that runs centres that support people with cancer and their close relatives or loved ones. They provide a service that is unique, really, in supporting the whole person. So people have got somewhere to go to take financial worries. They can receive counselling. They can do some exercise, maybe even massage. We haven't got one of those in Bristol. And so there are some people who are really getting behind a fundraising effort to enable us to create a Maggie's close to the BRI, and they have identified a site, and we're working closely with Maggie's on that. So I went to an event to support the fundraising effort around Maggie's. Nationally and regionally, it is what it is in the paper. I suppose two things to highlight. There are now quite a number of us that are group chairs, and so we have come together in a sort of national learning set. So we had our first meeting a couple of weeks ago. That was really useful. And we'll be having a programme of work to develop our thinking together and to learn from one another over the coming year. And not in the paper, because it happened since it was written, but just also to flag to people that I am now a member of the University Hospitals Association Board, which is now being hosted under the umbrella of NHS providers. So I'll be going to my first meeting there and will report back in due course. I don't know if there are things that two vice chairs would want to highlight, Sarah or Martin. That's it from me.
I think two quick things. One was I went to spend the morning at the Apprenticeship Centre, which is a virtual centre at MBT, and the thing that really struck me was the diversity and breadth of our apprenticeship programmes, the different levels of apprenticeships from young people of 18 through to people who are, I'll use it on mid-career, but in quite a long way through their careers, developing new skills and having the opportunity to enhance their careers. And that was really inspiring. And we had a fantastic Bristol Organ Donation Study Day. Mark facilitated the session before me. Really good session across the brief.
So happy to pick up any points anybody would like to explore more. But it is for information. So we will note that and move on to Maria, the Group Chief Executive's report.
It's a written report. It has been very momentous time in the NHS in recent weeks. We had the spending review with the 29 billion and huge commitment to maintaining the NHS, although at the time there was talk about sort of existential crisis around the NHS and being really clear that things do have to change So in support of where that money needed to go, we have had a 10-year plan recently published, which I won't parrot the 3 left shifts. I'm sure everyone knows them very, very well, but the expectation is that care is to be delivered as locally as it can be, digitally by default, in a patient's home or neighbourhood health centre, and then as a last resort hospital rather than the first resort that it has often become. Alongside that, there is an expectation that there will be a new operating model. We certainly know that ICBs, DHSC and NHSE, that there will be a lot of change there. And actually this week, I think in across the country with 42 regions going down to 26 in total, unless there's going to be any further intervention, I think that's where we've got to. They are going out for chair appointments. So this will happen very, very quickly, that we will have the new formation. So new operating model, new transparency of care, and that is a new NOF, a new national operating framework, which will be a performance assessment regime with a number of metrics. I've included them in my report, but there'll be an expectation that every provider will go into a league table, a segmentation of 1 to 5, 1 being top and 5 being an intensive scrutiny regime, and all that implies. So very keen that we are somewhere near the top. Results will come out for Q1 on 17th of July. So we'll be letting the board know then. They will be rerun at Q2 because there is an expectation that there may need to be some adjustments to the weighting on the metrics. So I will keep you posted. There's also been an announcement about a rapid review into maternity and neonatal services across the NHS with 10 trusts as yet to be finalised. You'll hear a little bit more about that later, but that will be underway. An expectation that a rather dizzying array of tools, perinatal mortality tool, how our LMNS is working, etc. I think there's going to be a full review of how all of that sits together to ensure that we don't keep repeating the same poor outcomes from investigations that have come out of Kirkup and lots of other reviews. I've just to be specific, in the Southwest, the expectation is with the new ICB changes that BNSSG, our system, will cluster and then merge with Gloucestershire. That's where we are at the moment. That gives us a population of about 1.8 million. The expectation was around 2 million. So there may be some challenge that we're a little bit under that, but actually in terms of patient flows, that makes very good sense. Ingrid's mentioned the St Michael's roof fire. Again, I'd like to add my thanks to Stu and the team who sorted things out, and obviously there is an investigation going on into causation, lessons learned, and obviously we have our partners with Bristol City Council on the photovoltaic panels. That is something that we will have to look at across the trust now. I think most of the rest of it has been covered. The Global Ambitions Working Group, which a number of us were on, some very positive feedback from that. You've got a number of partners, an increasing number of partners globally who are expressing interest in working with us. So what we're doing at the moment now is determining our criteria for success, making sure that we are getting the basics right, but also not missing opportunities for innovation and partnership. And certainly around the government's digital agenda, the expectation of making good connections with independent sector and with global providers is something that is felt to be a good thing, and something that we're very much on top of. Just lastly, I did want to mention one of our consultants who works at Western, actually, Dr. Professor Palad Sindel, who was awarded an OB in the King's birthday on this recently. So congratulations to her, who is also Chief Executive of BAPIO at the moment.
Thank you very much, Maria. Anything people would follow up on, Rosie?
This might be a silly question. Thank you for your report, Maria. But the oversight framework, being a group model, do we get 2 ratings or 1?
At the moment, 2.
2.
Yeah, still provider based.
Any other questions? No? Okay, so thank you, Maria. Again, the report is for information. And we'll move on to the Green Plan Refresh. So welcome to Sam, Sam Willets. And Neil, do you want to say anything before Sam comes in? Happy to hand over. Sam, welcome. If you'd like to just take us through the highlights and we'll pick up.
Sure. So NHS England asked us to refresh our green plans by 31st of July. They only issued the guidance relatively recently, but we're ahead of the game on that one. And it's a good time to refresh our plans, as we've had the existing one in place for 3 years, and quite a lot has changed. And it's allowing us to really work out what we're going to deliver by 2030. It's a system-wide plan, which we developed with our partners, and it went to the ICB board last week, was approved. And the ICB blueprint actually says that green plans will be moving to providers. We're already ahead of that, my role being based at NBT, that that's where our sustainability strength is within the providers. So we're ahead of that process too. I'm really proud that we've been successful in really embedding sustainability in our activities and processes. It's not a separate thing. That's been a really significant step. And we're going to move that further, particularly with clinical transformation and how we can really embed it in our way we do things clinically. The other area with this refresh is we had early community engagement, which I'm really pleased we did before we'd even started looking at changing the plan. We've involved the community leadership panel on climate change and just transition, who were able to give us their input. It's been really valuable in shaping the way we've developed the plan, and we've woven it through the plan, their advice. The biggest change that we've made in the plan is splitting it into the 2 areas, the areas that we are able to directly control, and those that we can only influence. And where we can only influence it, we've aligned with the national targets as opposed to our 2030 target, to reflect that that's the most likely trajectory. And I think that's a crucial bit, is how we make this a realistic plan of what we're actually going to be able to deliver. Plan also says we want to be leaders in sustainability. We're already recognised as leaders nationally, and we should be proud of that, because we are really making progress. And there are areas like green social prescribing, which is a system we are world leaders on, and we're now bringing that into the hospitals trusts as a really big success story. And that system collaborative approach has been really key to our success. On the finance side of things, the system capital prioritisation process has allocated £3 million as a minimum to the Green Plan Steering Group to allocate, which has allowed us to use those funds in best possible way as a system. And the hospitals particularly have had success in leveraging a lot of grants by using that financing, making most of it. Though the main grant scheme, the public sector decarbonisation scheme funding, has now ended, but that's there should be opportunities for private financing, and that's coming out in the 10-year plan, that we should be able to pursue that, which has been always the most realistic route to be able to fund these programs. Our biggest impact is actually through prevention, and that's really, how this aligns with our national and local strategies, particularly our Healthier Together for 2040. But that's the biggest impact we can actually have is working on that prevention agenda. And the plan reflects that in other areas. And it's not just the sustainability team delivering this, it's all of us that have got to deliver this. We will be refreshing the delivery plan, which sits behind this, with detailed actions. That will be refreshed by the autumn to update all the actions, but also to really deliver that detail and also the responsibilities. We'll have named executive and director leads against those actions within the delivery plan. So we're really clear on responsibilities and making sure this gets delivered. So I'm asking for the board to approve the plan today, and if anybody's got any questions.
Thank you very much, Sam. Arabelle, close to your heart, I know. Yeah.
So I really I thought it was a really good read, actually, and I'm really pleased to see us being more realistic about what we can do by 2030 and beyond, because it's bothered me for a while that we have a sort of stated target out there with no detailed plan that shows how we can actually achieve that target. So I think it's pragmatic and sensible to split it the way you have. So that's great. I also think it's great to see it more as a holistic thing. So trying to link it to the 10-year plan, and it's not just we're doing this for sustainability, but this for something else, and actually bringing those things together. So that was great. What I wasn't clear on was kind of on the delivery, like whose plan actually is it? Because you talk about the system, but then you also talk about providers. I suppose I'm slightly concerned about all the changes that are happening at the system level, and whether we're just going to lose momentum if it's a system level plan. But then you also said actually it's coming to providers anyway, but so much of this has to be solved at a system level, doesn't it? We can't possibly solve it within the acute trust. So I just wondered if you had a bit of commentary sort of around the risk there. And just my final question, which you've answered, was about the actual detailed plans. I think you said that's autumn. So yeah, maybe if you could just give us some commentary about the realism with all this sort of turmoil and everything changing, about actually being able to deliver.
Yeah, well, I'm glad you picked up on it being embedded in our wider plans, and that's a really important bit. And actually, as part of being realistic, is the sustainability team isn't going to deliver the prevention agenda, and that it's part of that wider process. In terms of our resilience to the changes, I think the way it's evolved in that most of our sustainability staff resource sits within the trusts, and that we've been working as a single team, but also bringing in AWP and Sirona and supporting the ICB. So actually, I'd say we're already in a strong position, and the work streams that we have existing are system wide, although the core of them is the acute trusts. So I think we're actually in a strong position, and the governance is already set up as a system wide approach, but heavily based within the trust. So I think at least for the moment, we are kind of sheltered from that wider changes, and I think it's been, whilst it's been supported by the ICB, it hasn't been led and pushed by them. So I think using where our resources are and is allowing us to be resilient.
Okay, fingers crossed. Sorry, and I did have a moment just about cons of it, particularly given we had a very clear stated public ambition from that 2030. I saw that you said it's going to be published on the website. So anything more proactive?
So I mean, one of the things the 2030 target is a common one we've had as part of the One City plan within Bristol, and there's a lot of other organisations looking at making these changes. And I think we will be looking at a kind of collective approach to that. It was actually We the Curious who came up with a similar split of what they could directly control as well. So we've been talking to others about how we change our target, and I think probably having a collective response of how we communicate that change is going to be the best approach. But on the communication side, it was actually the community panel that actually has really given us some really good advice on how we should be communicating this, and that's being built into our communications plan and strategy. So that was a really valuable insight that came out of the process as well.
Excellent. Thank you very much.
There were three other people waiting to come in, so I'll start with Neil and then go to Roy and Mark and Rosie. Okay.
Thank you. A really good plan. I'm just mindful though that I'm aware that 17% of the NHS's carbon footprint is in patient transport, and therefore I'm curious about how we might be able to, as a board, do more in terms of using the shifts to the left in terms of digitisation, moving care closer to patient homes, how we might take advantage of this plan in terms of perhaps moving more of our service in that direction more proactively and supporting you in some of those ambitions. It seems to just be a little bit of all the things it comprehensively covers, it doesn't seem to look at the carbon footprint for travel.
Yeah, I mean, the transport side, we've focused on what we can directly control, so our fleet and that side of things. And the vast majority of the transport is associated with staff, patients, but also all the stuff we buy is a huge amount of transport travelling around our sites. The key bit that we can do is influence the transport strategy. I mean, if we're representing 39,000 staff and 1.8 million patients, actually that's an awful lot of important influence that we need to be establishing. But I think that going to your point about how we change our services and deliver them, what we need to be doing is making sure we are absolutely thinking about those transport implications of when we redesign our services and capturing the benefits of the carbon footprint of how we deliver things differently, and making sure that's built into how we look at any of our transformation plans.
Yeah, thank you. I just wondered whether we were able to perhaps articulate what our ambition might be in terms of a shift in services in that direction. So a proportion of our outpatient activity, for example, where we don't invite patients to come into the hospitals.
Yeah. I mean, I think I suppose that's kind of where it's not a sustainability thing to lead on that. It's absolutely got sustainability benefits, but it's actually what's best for our patients in terms of how we deliver that service. So I wouldn't want to set the target, but I think we should absolutely.
No, I just think it's important to consider how it might support you in moving further by perhaps us establishing some of our ambition and targets around that to support the direction in the plan.
Absolutely.
Thank you.
And Neil, just to note, that is absolutely at the heart of both the 10-year plan and the joint clinical strategy. So it's something that as a whole board we can do, which will also support the Green Plan. Let's move on. Roy, I think you were next.
Thank you, Ingrid. Few very quick questions and reflections, perhaps. The first one being, with the Gloucestershire becoming part of this in the next 5 years, sort of just a sense of, is there a green plan for the broader that we're considering? So that's sort of one question and thought. The question on transport, but you've asked that. In terms of metrics that the system are looking at and that the providers are looking at, there is, how do you make sure they're aligned? So as an example,
zero waste to landfill. UHBW has a different target than what we have in the report, which is I think 2040. So how do we make sure that they're aligned or closer together and providers are working towards the same thing? And the last one around carbon footprint was in digital. I think that section is very welcome, but just to highlight one thing, if the general direction is to use more cloud computing and AI and so on, that does come with a big cloud footprint. Estimates are saying at the moment where carbon footprint is greater than the aviation industry combined. So especially in the next 5 years as well, how do we make sure that cloud computing AI is used in a responsible, sustainable way, because there is a footprint to that.
Yeah. So on the aligning with Gloucester side of things, I've already spoken to their chief finance officer, but they actually have very limited sustainability resource up there. So I think they're already interested in how they can lean in and what we can start doing some projects immediately with them, and then look at how we can align and support them. So I think I see it as a positive step of actually we've got good progress here and we're able to help bring them along with us. And there will be things we learn from them too. They've done some really good work on the procurement side as well up in Gloucestershire. In terms of the aligning our targets, I think this is we've done as a system. We've got a clear thing, but within that delivery plan, where there are differences between organisations, we will make that clear as to if somebody's got a different target. But for most of them, I think we should be able to align them. And the AI challenge of those demands, I think it's like any of our other plans, making sure that we are assessing the whole the wider impact, and not just chasing the new latest thing, but actually assessing how do we make sure we're not building masses more energy demand as part of our services. And I think that's part of the wider digital strategy, is looking at rationalizing server rooms and things like that. So I think it's making sure it's part of that process of the demands.
Okay.
Hey, Mark.
Yes. Thank you for the plan, refreshed plan. It's great to see the position of the sustainable healthcare collaboration in there. This is a relatively new thing. And I know Sanjoy has obviously been Sanjoy Saar has been heavily involved in this. But you probably can guess what I'm going to say. I think what's missing is the linkage through to education providers, tertiary, otherwise, because there's phenomenal work happening around areas like air quality and around sustainable continence support, for example. These sorts of things, which are community and acute based, I think could be cemented in really easily in terms of say, this is how we're going to work with educationists and researchers, of which there are researchers in the trust, we know this, or the group. I think we could do that to really show and cement in at a system level how we're working together, because there's some really brilliant work happening. People like Ben Williams, who's an absolute world-class air quality researcher. I'm sure that could be plugged in to this, or some notion or noted there as well. I was curious, back to Arabelle's point around communication, around what does this look like and feel like on the ground for staff in terms of, and patients, I guess, in terms of, am I being a good citizen? Am I putting my stuff in the right bin? Really, really basic but important points. How am I going around my carbon footprint each day that I work? I think that culture and mindset. And then I guess the only other bit was, it was great to see what I think are classified as OKRs, which are objectives and key results. You can see them under each of the sections in there, but having some tangible owners, and I know it's a plan and there's a delivery beneath this, but even if it's at a high level, saying, look, it's this person's responsibility at the director level for X, Y, or Z. Again, only meant to be helpful points. I think it's a really rich document, and probably one of the best I've seen in terms of as a kind of, from a organization's perspective. Lots that we can learn, I think, in UWE Bristol about this as well. So,
yeah, the connection with the universities is really important, and Sanjoy has been fantastic in developing that. And I think it's how we really make that a strong two-way relationship rather than it being something that we're looked at, and you know, some interesting things, but actually really how do we use it to drive forward making change, I think is going to be key. And I think, yeah, I appreciate your points and governments. Thank you.
So can I just ask about the link with quality and safety and inequalities? Because, you know, there's a growing body of evidence in terms of how sustainability and patient safety are inextricably linked. And, you know, lots of examples like the use of pre-filled syringes, which are much safer and much less waste, for example. And with inequalities, I guess, you know, huge inequalities in health care, which are exacerbated by those impacted, and that there's a lot of talk about the climate emergency and how it's going to have a much more disproportionate impact on people who are already subject to health inequalities, and air pollution and air quality is an example of that. So my question is about how we're linking these agendas together, and you've mentioned about sustainability impact assessment here. How are we kind of linking the equality impact assessment and equality impact assessment together with that sustainability impact assessment so that actually we get that rounded picture, which will actually be beneficial for all of the different areas?
Yeah, I think it's how we embed those. I mean, I'd like to, in some ways, see combined impact assessments as a way forward, rather than us having these separate, you know, equalities and sustainability impact assessments. And actually, that in itself, people then seeing it through that combined lens would be a useful approach. But I also think it's how people understand it in terms of the work they're doing. You know, that anybody working on prevention is tackling climate change, and actually seeing how those agendas mesh together is a kind of it's not a sort of instant fix thing. It's more people understanding how they are contributing to it, and how these things work together. So I think I guess it's a gradual cultural change that will hopefully deliver that. But really making it clear where we're doing that, where we are able to make those decisions. I mean, I suppose on the safety side of things, that our infection control teams are actually absolutely at the core of the clinical transformation process, as they are coming up with a lot of the ideas, which they're gaining from other teams around the country as well, of sustainability projects that we can deliver, which are safety related. So I think that's been a real breakthrough of really having their commitment and kind of leading on it, which has helped on that, bring that agenda together.
Thank you. I was going to say no more hands, but here's Martin. Last word, Martin.
On this most been said, it's great to see the aspiration and a sense of realism, I suppose, in the 2030 plan now. But even with that, you know, there's quite a lot of work to do. You know, decarbonising the estate, getting rid of the combined heat and power, and I guess bringing in some sort of heat pump technology or something. I just wonder, when we get to the delivery plan, you know, how we make that real and how we, you know, reflect it in our medium-term financial plan, either capital or revenue consequences. It's actually quite a short amount of time till 2030, isn't it? So we need to, knowing the amount of time estates things take to deliver, you know, it's all got to be in the next iteration of our plan to see how we work that up and, you know, what choices we have to make it real and deliverable, I suppose. But I guess Neil, you'd agree.
Okay, so a number of points have been made. I think a welcoming of the realism of this, and a number of suggestions about how we can better join up the dots around various elements of the trust work, whether that be clinical safety or estates or other factors. Also an acknowledgement of the system partners and the impact of what we can do better together, including as the ICB moves into Gloucestershire as well. So I think some of these things probably can be wrapped up in the delivery plan, which I know is being refreshed alongside this. So are we happy to move to recommendations? Okay, so we've been asked to discuss the changes and to note that the plan does meet the requirements of NHS England. We've been asked to note also that the plan is or has been taken to the Integrated Care Board and to partner boards for approval. So this is a whole system plan. We're noting that the delivery plan will also be updated then, and that there will be the point was made about comms, wasn't it? That there will be a public facing green plan as well. So having noted all of that, we're being asked to approve the refreshed plan. Are we happy to do so? Great. Thank you all very much indeed. We'll take that as carried. Thank you. Thank you, Sam. Thank you to you and the team for the work you're doing on this as well. Greatly appreciated. Hugely important agenda. Glasses. Let's move on then to the Maternity and Neonatal Care National Review, which was referred to in Maria's report earlier. So, Steve, what does it mean for us?
Yeah, thank you. Thank you, Chair. So today I'm bringing a paper in response to the Secretary of State's announcement of the rapid independent investigation into maternity issues, neonatal services, and the accompanying national letter from Sir Jim Mackey and Duncan Burton, Chief Executive of State England, outlining the 5 immediate actions required from all maternity providers in England. We know that obstetric incidents can be catastrophic and life-changing. They touch not only the women and babies involved, but ripple out to families, communities, and of course, our teams. These 5 actions are not unfamiliar to us, and both maternity services are rated good by the CQC. They've both achieved their 10 safety actions for maternity incentive scheme, but the actions do reflect long-standing priorities for safe, compassionate and equitable maternity care, and offer us a moment to pause, to take stock, and reaffirm our commitment to women, babies, families and the colleagues that we serve. The paper sets out our current position across the Bristol NHS Group, and I'm hugely indebted to both teams who have supported the production of the paper. But it sets out the work we're doing against the 5 actions. So it provides assurance that we understand our current position. It shares examples of good practice and areas of strength. And if you read the paper, there are 2 brilliant examples, or many brilliant examples of shared strength, examples of where we've worked together, but also identifying opportunities for ongoing development, leadership attention, and system-wide improvement. So the board is asked to note our initial response and give consideration where we may or want to go further and faster and support the continued alignment of maternity transformation across the group. I wonder if at this point, Chair, if I might just invite Rosie and Kelly as our non-exec maternity safety champions just to offer any comment in this space.
Yeah, happy to go first. Yeah, I think that, the paper is very comprehensive in listing all the important and innovative things that we're doing, so I won't repeat that. But I think what it does do is provide some insight, actually, and some reassurance into our culture, which I think is differentiated by the curiosity and commitment of our workforce to not only being data-driven. If you look at the perinatal quality surveillance tool that we look at, but also engaging with patients and their commitment to best practice and continuous improvement through all the things that are going on. I think that the thing that I would call out, which is our biggest risk and challenge to our maternity services, which isn't a surprise to anyone, is our estates, because it presents a risk. It presents a risk in terms of capacity. It presents a risk in terms of being fit for purpose. And we also shouldn't underestimate the risk in terms of our workforce and the morale, the impact, particularly in our situation when we've just got a new elective care building across the road in MBT. So I think those are the things that I would highlight. Steve, thank you.
Thank you. And anything to...
Well, just to say that I think the culture bit is so vital, and I think it's clear that both trusts are doing a huge amount of work, and that's great to see, but I don't think we can do this kind of look at it once and then we're done. I think we need to have this continuous kind of laser eye focus on the culture. What we know about maternity services that do have more problems than us is that there is very hierarchical cultures, that people blame each other when things go wrong, and there's this kind of fearfulness about blame, and when they don't learn from things that go wrong. And I think particularly as we're going to the group model and moving two different cultures together, I think it's going to need more focus than ever, and we need to really eliminate those kind of hierarchical behaviours. And I was really taken by what Melanie was saying earlier about listening to patients, because quite often when things go wrong in maternity, it's because people haven't been listened to in terms of the patients have raised concerns. I don't think something's right here, and they're not listened to. And I guess that's something as well that is a huge cultural change, that we've got to move from this paternalistic hierarchical behaviour to people really being partners in care with women and their families, and really listening to what they've got to say. And I think there's really great action here, but I think we can't take our focus on it needs to change in terms of those behaviours as well.
Okay, thank you. Anything to add, Steve, before I go?
Well, I think the only thing I would say, having kind of done the final editing of the paper, is that there are lots of great examples from both organisations. And I was sat there thinking, both from an MBT and a UHBW hat, thinking that's a good idea. Why don't they do it? That's a good idea. Why don't they do that? So the opportunity to come together as a group to think about transformation, but also learning together and learning for our population together is really, really, really important. And there was no better reason to become a group than around maternity services than this would absolutely be.
Okay, thank you. Sue, you were ready.
Thank you. I think it's a great paper, and actually it's been really helpful, as Steve says, to force us to bring together and have a look at it with a magnifying glass. And this is great work, but it is quite fragmented. I think there's two areas that I think, for me, at COC, we have on a monthly basis, we look at the PQSM and we have deep dives. I think listening and learning is an area where I still don't think we're not doing enough. We listen, but we cannot evidence that things always change quickly enough in practice. And I think there's repeated messages from mothers, fathers, families that actually they don't always feel listened to. And then we're not demonstrating always that we're making the link when things go wrong to actually learning and making a change. And then I think the work around tackling inequalities, we've only just skimmed the surface. And with some great work with Black maternity monitors, but if you're sitting in Weston and you're thinking, I've got to go all the way up to St Michael's and I've got a maternity birthing centre at Weston, I don't know that we're really doing enough in terms of inequalities of access, not just around the Black maternity matters. But I think it's actually been a really good learning opportunity, I think. But I think listening and learning and tackling inequalities, we can never do enough, really.
Thank you. And I think, Glyn, you want to come to...
Yeah, just responding to Rose's comments. One of the things we had some concerns about over a couple of years is that we're getting very, very few freedom to speak up. Excuse me. Very few freedom to speak up for things being raised through our Women and Children's Division. So we've redoubled efforts on getting FGSU champions in there, and we're now starting to see some freedom to speak up things going through there. And we actually think that it wasn't that people were frightened to speak up, but there were so many other reviews, investigations, etc. happening that staff had many other ways of raising their views and thoughts. But we're now starting to see them start to come through there. So that is, because I agree with you completely. If it's the dog that doesn't bark. It's if we're hearing nothing from somewhere, it doesn't mean everything's okay. It means that people aren't raising what they should care about. But that gap has closed out.
Thank you. Oh, Linda.
It's just very supportive of the points raised about learning, sharing best practice. And I think coming together now, we've got a real chance to align, and really focus on a few key targets that both trusts can go for. And secondly, I thought there was some great examples in there. And I guess my challenge would be, how are we getting those communicated out? How do we actually celebrate some of the successes, talk about the good work that's going on? Because very often all the stuff that's raised is negative things. And there's some really lovely work in here that we're doing. So how do we build on that? How do we focus, get real clarity and focus on the key things that will move the needle And then how do we communicate those successes or share them or engage with the broader population? So I think that'd be really helpful. But good piece.
Yeah. Thank you. Just looking forward a bit, I think we need to be just thinking about the future pressures on this service. We've got potentially housing growth. We've got lots of new homes being built here, Western to Sue's point, but also the ICB have started mapping housing across local authority areas and housing plans, planning applications, etc. And I've encouraged them at the meeting I was at when they presented this to think about what that means for our future secondary care services as well as the important community services that this workplace. And so I think we will see potentially further need for maternity services provision, and increasingly we see a lot more complexity. People needing perhaps more care than in the past. And it's important we can deliver that in a safe and appropriate way.
And Martin.
Yeah, just as already mentioned, when you read this, it does pick up, and it's striking sort of some of the differences between the different sites. And you could say, great opportunities for learning and some standardisation, but you also do get the sense that some of those have grown up out of the needs of the communities that are being served by those departments. So it's obviously important that we maintain, the differences in the learning where appropriate, to provide the sort of local services that we've heard about earlier on.
I think that's all the hands. So really helpful discussion, I think, and thank you for the paper, Steve, because we've seen mapped out there the responses from both trusts to the 5 points in the Jim Mackey Duncan Burton letter. And as you commented, Steve, lots of mutual learning to be done, and the case being made right here, isn't it, for the joint clinical strategy in relation to maternity services. And happily, we will be hearing from 2 of our community midwives from each trust later on today, so it will be really good to hear their reflections on some of this as well. But some of the points that are being made are around, yes, we've got issues with estates, but actually the listening and learning piece is absolutely crucial. Continuing to have a focus on inequalities and building on the really good work that's been done through Black Maternity Matters, and therefore celebrating the good, because we are in a good place in both trusts, so let's not lose sight of that. But also, let's future-proof the thing. Let's look at demographic changes and potential growth differences, emerging, increasing complexity and those sorts of things. So it's a good picture. It gives us a lot of assurance, but more that we can do to make it even better and more responsive, as Martin said, to the diverse communities that we serve. So we're being asked to discuss the initial response under the 5 actions and to consider areas for continuing development, improvement and oversight, and any other assurance required. Does anybody feel at this point the need for additional assurance on the 5 areas that we're being asked to respond to? Raise it.
I don't think we need additional assurance now. That what I would say is that when we're doing as we get the updates with the maternity clinical services strategy, we ought to be kind of having some assurance at each stage about how these areas are being focused on.
Okay. Can we do that?
Yeah.
Great. Yeah. Okay, thank you, folks. So that was an item for discussion, and we can move on, therefore, to the Integrated Quality and Performance Report, which, of course, covers both trusts side by side. I'm thinking that Glyn and Stu might want to kick this off, and then we'll go to the group directors in terms of their particular areas. So over to Glyn and Stu.
Okay, shall I?
Stu.
Shall I kick off with MBT? Sure. Yeah. So from an MBT perspective, our diagnostics continues to be in line with constitutional standards, and 52-week position is in line with the national requirements of less than 1%. And we have a plan to have that eradicated by the end of quarter 2. Our cancer performance has shown an improvement month on month for the third month in a row. However, we are clearing backlog, and as a result of clearing backlog, our 62-day performance is still below where expectations are, and also behind where we said we would be on plan. And that position is probably going to get worse again next month before turning the corner and start to reduce the backlog proportion of the people we see. So we're seeing the planned level of activity that we said we would do, but there is a higher proportion of it that is coming from backlog rather than being less than 18 weeks. So it's that will improve over time, but we're going to get a little bit worse before we start getting better. In terms of UEC, we are only 1% behind where we said we would be on the plan. So we're at 62% of patients being seen within 4 hours against the target of 63. However, that is way behind where we need to be for our population. So we have a sort of 5-point plan that went through our Quality and Oversight Committee this month, and we expect that to start to have improvements. The implementation of that will happen over the next 10 weeks or so. So we expect to have those improvements started to happen at the end of this quarter, into quarter 2. However, there are some tactical operational things that have started already. So on 45-minute waits in particular, there is a real focus on any ambulance handover of more than 45 minutes. We've been slowly improving our average performance, and our average performance continues to improve into June. We've implemented a new SOP now to try to avoid any breaches of 45 minutes, and I'm really pleased that our May performance was 44% of ambulance 44 minutes was the average handover time. For yesterday, which is the 8th day of our new SOP in place, we've hit 22 minutes, which is very early indicators on one day only. But we're starting to see some evidence that the tactical responses we're putting in to gain quick improvements buy us the time to make the larger scale improvements ready for as we head into winter. So I don't really want to take questions on MVT or hand over to Stu.
Let's the other two, and then we'll take them now.
Thank you, Chair. So, for UHBW, I'd say the overarching picture is one of good and improving position despite significant challenges. I think the challenges I would highlight are those of demand, acuity, and the system delivery of which we are a part, and the criteria to reside performance remains very challenged. In terms of our unscheduled care performance, our 4-hour performance as of yesterday, just to update the IQPR, 77% with uplift. So that was assuring to see, and people can see in the IQPR that both of our 12-hour performances, i.e. total time spent in department and trolley weights, are on a very significantly improving trajectory. So that's very positive. Ambulance handover. Our mean ambulance handover for June is 32 minutes. Now, people will recognise that the metric here has changed to a zero tolerance of a greater than 45-minute handover time. And that is not reflected yet in the IQPR, in which we have a 1-hour handover time recorded in performance against that. Glenn and I have discussed and agreed, and we wanted to bring it here for approval, that we will, going forward, look for the I think it is absolutely doable that we will convert the 1-hour handover metric to our 45-minute maximum handover tolerance, and be able to report that in the IQPR instead, which I think aligns with that national requirement. So as long as people are happy with that we make that change, we can look at that going forward. Our current average handover is 32 minutes, and I would just say is actually entirely consistent with delivery of 45 minutes as a maximum handover time, although we have had 45-minute breaches. Our cancer performance is for both 28-day FDS, 31 and 62-day standards are all within national standards, and our diagnostic standard performance, as you know, is challenged but improving, and with some developments which will be coming online outlined in the paper, what we believe will continue to improve, especially after July, with the implementation of the CT MRI scan in Western General Hospital. So that's probably what I was going to say, and happy to take any queries.
Thank you very much. Mark straight as it goes.
Well, I hope it's okay to talk about the no criteria to reside at this point. Is that the no criteria to reside? Can we talk about that here? Is that just looking at the trend, particularly for UHBW, Stu? Obviously, it's residing higher than where we'd like to be. And I'm just conscious of where it was this time last year and the impending, I know it's they talk about winter, but winter's coming, as they say. Just the kind of plans really, because we know that it can be a compound effect. And just thinking about how each of the pathway transformations are working. Could you say a bit more about that? And happy to have that linked to North Bristol Trust as well in terms of how that's working to drive down the no criteria to resolve.
Yeah. So the no criteria to reside performance in June was as equally challenged as you see here, just to put that on the table. As UHBW, we're running along at about 22% or something, and of course it's different on the different sites, but on average about 22%, and it's worse than Western, as part of that, as you know, the system aspiration is to achieve 15%, and there are a number of work streams in play to deliver that. I think this is something that, as part of our winter planning round that we're going through now, we really, as an organisation, need to ensure that the system is responding to the current pressures in the right way. That is an ongoing piece of work, and I wouldn't like to sit here, Mark, and say that I'm totally assured about where we are at that position at the moment, especially with June's performance. Yeah. But nevertheless, it's definitely an issue which we recognise and are working hard to resolve. Yeah.
Thank you, Stu, for your honest answer. Just a little flag, obviously, with the refreshed one city plan within, I'm talking about the Bristol City Council here particularly, there's more of a focus upon housing, affordable housing and social housing, and this will have an intrinsic direct link to no criteria to reside, because things are either going to be changed or moved around. So it's going to become probably more challenging to place patients in some circumstances outside of the acute sector. So it's a little flag there as well.
Yeah, I mean, clearly demographic, as we discussed just now, that demographic change is going to have an influence on this going forward. But saying that, right now, I do think there are things we can go at to improve our performance, especially over winter. And it certainly looks as if, for example, some actions we could take in the P1 pathway could actually genuinely improve our situation. So I am hopeful, but I would not like to say that I am totally assured you can deliver 15% in a year as a system. Remember, this is the system requirement.
Sean, were you coming in on no criteria to reside as well? No, okay, I'll go to Glyn then.
Yeah. Yeah, there's an added dynamic amongst the ICB changes as well, that as part of the change to clustering, the ICB loses its responsibility about system performance. And whilst the region will step in to do performance monitoring, that's very much a rear view, what you're doing. We need to get more active in that space, in sort of owning the performance agenda, and Nick Smith, the coup, is talking with Dave Jarrett about how do we manage the transition of ownership of the chairing and the drumbeat of those meetings, to try to make sure that we start to make progress against no criteria to reside over the summer. Because if we run into September at 22%, it is only going to get worse. We've got to get ahead of the curve.
That's where the local authority policy becomes really important. Absolutely. Thank you both.
So good. It's a very well made point about system changes and 10-year plan opportunities for FTs. But there may be a space where we can ourselves take more agency in this. Not saying that we haven't been working really hard on it, of course we have. But we're just structuring more possibilities then for us, which I hope we can take advantage of. And with John in the room, I'd just like to acknowledge also this is something that governors at UHBW have been raising rightly, very strongly from the perspective of people who use the services and the impact that that has on them. And there's a conversation coming up, is it next week?
Yes.
Yeah, between Maria and myself and the governors to hear more from their suggestions of how you might be able to work differently on this agenda, because it does feel like Groundhog Day. Pretty much every meeting we have, we're rehearsing this problem, and something absolutely does need to change. As you say, the pressures are only going to grow.
And we will have the ICB and the council in attendance at that meeting. But I do think there are absolutely opportunities for us to move into that space of taking control over pathway, and knowing what avoids admission and what expedites exit and discharge is probably more easily done through providers actually. So that's where we're trying to influence.
Thank you. Sean, you were going to raise a different point, aren't you?
Yeah, thanks. Mine's just a general point really on IQPR. I think seeing the two side by side was quite enlightening in a number of ways, really. Because
sorry, Sean, could you speak up? I'm really struggling.
It's very hard to hear.
I know the acoustics in there aren't very good. Just going through the IQPR and seeing the two trusts side by side, I found it quite enlightening going through in a number of ways. My pack is littered with yellow stickers going, can NBT learn from this? Can UHBW learn from this? Why is this slightly different? So I think there's a broader thing of alignment and learning. So I think it was very, as I say, enlightening to see the two side by side, just to see that, and it raised loads of questions. So I think there's 2 points really. There is perhaps we need to do some work around aligning the measurements so that we can get a better comparison, and really look at it and see, are there some learnings for each trust from the other? I mean, one that jumped out was ambulance wait times. Why is there a 10-minute difference between NBT and UHBW when, broadly speaking, the same ambulance service? So you try and think through what that might be, the difference. Are there some learnings? Is it a process thing? I don't know. I just think it's something to take away.
Absolutely. Great opportunities inherent there, aren't there?
Yeah, and it highlights it as well.
Richard.
Yeah, so really it's a common theme. Having the KPIs consistently coming up with F- is for a board not something we can live with for a long time. With winter coming up, I know there's a winter plan which generally focuses on, if you like, what we're going to do with additional beds. I think it actually needs to focus more on, as you were saying, Stu, what we can do to bring these stats more in line with the P1 pathways as part of that. We need to have something that addresses this, as opposed to just the winter plan, sort of saying what we're going to do if it all goes wrong type of thing.
Can I come back to that? Thank you. I think it's a really good point, Richard. And I think, and I know that historically the winter plan has been, I think it's too strong to say formulaic, but has followed the same type of development and then presentation. That is recognised, and so there has been a challenge this year put in to do exactly what you said, which is to broaden the scope of the winter plan and to address some of these really core issues. So I think what you've just said is exactly where we've got to.
So thank you. So overall, as you commented, an improving picture. Huge challenges though around particular areas, especially no criteria to reside, which then impacts on other things like ED weights and stuff, as you know. So thank you for the efforts of the teams, the operation teams, the clinical teams, for the work they're doing on all of this, because it's hard. Okay.
touch upon people as well?
Yes, shall we do that now? Yes, okay, so let's go on to the people part of and then I'll come to you, Steve. To the people part.
Kick off on this one.
So over to you.
I might kick off on this one because ours
Yeah,
is
go on.
quite short, which is that we are achieving
Yeah.
the standards as outlined in the IQPR. We do not plan to rest on our laurels though, and specifically focusing our works on staff retention and well-being going forward. Whilst I do have the mic for a moment on people, I will flag up that we've just had the news that the BMA have voted to strike for the trainee doctors, and therefore it is likely that we're going to have some challenges in that area in the not too distant future. I think that's it's a mandate.
For 6 months. Up to 6. A fresh challenge.
A fresh challenge allows. But nevertheless, there's nothing more. I'm happy to take questions, but nothing else I wanted to particularly say on the Peak and Metro.
Thank you. Anything, Glenn, from
The increase in vacancy rate is twofold. One is we've now the budgets for the elective centre, or the Bristol Surgical Centre, have now gone in, and so there's a gap as we're recruiting. We're not worried because they'll be in place. We've got plans to have people in place and recruited, but that vacancy rate has gone up slightly there. Our sickness absence rate is it's been at 4.6% for several months now, and the target is 4.4. We use a 12-month rolling average, and we are seeing monthly improvements, and so that the good news will start to come from that. So we're expecting to get down to that over the coming months. And then mandatory training, the big drop that's just happened is Oliver McGowan level 2 training has just dropped in as mandatory training for people. It's a full day's course, and it is going to take us about 3 years to get all of the staff through that course. And so we need to be able to reverse that out to say, with the exception of that, how are we doing on that mandatory statutory training? Because it is going to be such a big driver of a large gap at the moment.
Thank you. Any points to pursue on the people part of the report?
Yeah.
Oh, thank you, Kelvin.
I just wondered how different the approaches are between the two organisations when it comes to the nuts and bolts of handling sickness, because often getting people back to work effectively is is the most effective way of actually retaining a sort of decent sickness level and a sort of well-being offer we might have. And sometimes long-term sickness, you only have a few, it could bring the numbers down quite significantly. So I just wondered, is there quite a different approach to both organisations, or are we generally aligned?
I think they're fairly similar. If you look at the numbers, we're at 3.9% PUHW and 4.6%.
I'm not talking about approach then,
All right.
percentage. I'm talking about how...
No, the approaches are pretty similar. The two teams have been working to align processes more and more. In fact, with the exception of digital, the people team are probably the closest to sort of aligned processes.
I do wonder though if perhaps this might be something, now we have committees in common coming our way, that this might be something like a good topic for a committee in common to explore at some point.
See Linda nodding.
I think it's a very good point. I mean, I think proactivity and ownership are key, and if you can get a clear approach and you do it the same way across both of the trusts, you're going to get a good way of comparing and much better, I think, a better chance of a successful outcome. So I'm very happy to take it to possibly not the next people committee, because we already have the agenda for that, maybe the one after that, and put it on the agenda and have a discussion and see what we can do.
Anything else on the people aspect of the report? Okay, quality, safety and effectiveness.
Yes, thank you. Shall I start and Tim will add? Just, I suppose just to start off where Sean left off, which is around the PQSN at the back of the report. So there's probably over 150 measures around maternity service. So it's no wonder boards find it quite hard to pinpoint where particular concerns are, but also the way that both organisations present their data. It's the same data but presented slightly differently, which makes it quite hard to assimilate. So as we move forward and press forward, we'll seek to harmonise the way that we present our data. But just in terms of the PQSN, two things to highlight. One is the neonatal nurses qualified in specialty. Both organisations have struggled historically for that, but we are working with the South West Clinical Network and NIG Network to improve the provision of training for our neonatal nurses across both organisations. And also for MBT, then neonatal deaths in the last 2 months have been 0 for each month. I know that was an area of concern for the MBT team, but also came through at joint board a few months ago. Moving on then to infection control, C. difficile continues to be a challenge for both organisations as it does regionally and nationally. The report highlights a number of areas where we are seeking to make continued improvements, but I think still remains a slight challenge, of course linked directly with antimicrobial prescribing and working with our community partners to ensure that there's appropriate prescribing of antibiotics. And then in terms of patient experience, the friends and family test for ED and NBT is notably different than that at UHBW. When you look at the data, the principal reason why people are concerned is simply because they're waiting. And both matrons have been working together to see if there are any opportunities to learn from one another in terms of environment or other aspects of care that we can improve on. But fundamentally, patients are concerned about waiting. And my sense is the ED friends and family test is the most sensitive of all the friends and family tests that we do around patients' experience. The complaint response for UHBW is improving. It's good to see that, but I think it's fair to say that both organisations are underperforming against our ambition around timeliness of responses, and further work is being done by both organisations to ensure that we have a timely response to our complaints. I know that there's some work nationally going on to think through about the overall complaints approach that we provide for families to ensure that it's more personalised and more responsive. But for now, we're just under our own ambition, which we're seeking to improve. A couple of areas, both at UHBW and MBT, where we know that we can target and performance improve on. That's it from me. Happy to hand over to Tim.
Thanks, Steve. I'll just pull out a few pieces of information regarding stroke performance, if I may, because I know that interests a number of people in the room. So Glyn and myself were in Southampton last week, or the week before perhaps, meeting with Chris Whitty and Steve Parris, the National Medical Director, to hear about how our performance compares nationally and internationally, in actual fact. And Bristol and Western Group are now the largest provider of mechanical thrombectomy in the country. And the results of those mechanical thrombectomy in terms of full functional recovery are excellent. So that's the headline. Beneath that data, we have room for improvement, particularly around accessing our stroke ward, our stroke unit, our acute stroke unit. And this is because the capacity of that unit is outstripped by the demand. The demand is in two places. Firstly, we are seeing more strokes than we had anticipated. That's partly in our catchment area and beyond our catchment area coming to this group. And secondly, the demand is outstripped because we're unable to access stroke rehabilitation in step-down units and ultimately in the community, as well as we would have hoped. And this has at times meant we've had twice the number of patients who are actively being treated or recovering from stroke within the unit as we had anticipated and planned for. And that explains many of the metrics that you can see here highlighted, particularly the percentage of patients who are cared for immediately within a stroke unit within 4 hours. And actions are taking place, particularly with our community providers and internally looking at how we access and deliver stroke rehabilitation following the acute phase of the illness, both within the group and within our partners. And hopefully those metrics will improve as we see that capacity right itself. There is always a degree of disappointment in the number of patients who are having stroke thrombolysis within 1 hour. And this is quite a tricky metric to get heads around. And it's partly because our data doesn't quite marry with the data captured by the national team. But more importantly, the number of patients who receive pharmacological thrombolysis is extremely low compared to the number of strokes who receive, because the majority are access mechanical thrombectomy. And in actual fact, the statisticians from the National Stroke Team, the TASP, or the Thrombolysis in Acute Stroke Collaborative, which is a national team of which we are one of 12 trusts participating in that project, have acknowledged that the statistics are so low as to be really difficult to interpret. Secondly, we have the amount of time that patients spend in the stroke unit, and as you can see, again, there is room for improvement, and that really harks back to no criteria to reside and our ability to find suitable rehabilitation for patients who have had completed their acute stroke treatment. We do care for those patients. We don't put them in the corner of the ward. We do provide access to a full range of therapies, including building our own ad hoc gym to allow patients to start to recover to full function. And it was commented upon by the national team that we provide an excellent job in step-down stroke rehabilitation, although clearly that is not the best use of a HASI. If I could also mention the second point I wanted to pull out, which was VTE risk assessment. A number of people asked me in the corridor about this, having seen what appears to be quite a stark difference in VTE risk assessment completion across both of the trusts within the group. That is true. There are a number of actions in play to allow us to level up. So at MBT, it has been a particular quality focus for 2 years now, and it's taken us 2 years to stabilise what was a decline in VTE risk assessment performance, and to see some improvement and to sustain that improvement by a number of actions. And we are now going to share those actions with UHBW and appoint a single VTE clinical lead across the group to help to drive those improvements forward. And secondly, we know that we have received, we're in a sort of position where we cannot improve further until we've established electronic prescribing well and truly within the group. And we are watching with interest UHBW's performance in VTE risk assessment as it starts to access all of the potential benefits of the electronic prescribing rollout. And we hope to see that VTE risk assessment becomes a mandatory part of the prescribing to patients, and therefore we'll see a very significant improvement. Thank you.
Great. Okay, thank you. Now, I know Rosie wants to come in, and Sarah, you raised some important points about stroke at a previous MBT meeting from the Quality Committee as well, so it'd be helpful to hear any reflections you might have. Rosie.
Yeah, thank you. I was going to ask about stroke actually, and particularly around thinking about prevention in the 10-year plan with the number of increases. And I was reading a paper recently showing that the number of people coming to A&E and diagnosed with AF and then being sent away for their GP, and in the meantime having a stroke, which was avoidable if they'd been on anticoagulation sooner. And I just wondered, how confident are we that we're doing everything within the kind of gift of the organisation at A&E particularly, but also on the medical wards to identify atrial fibrillation and treat it appropriately, and so that we prevent these strokes? And also how much, given that increase, are we working with our community partners to kind of on that agenda?
So thank you. I think it's a fantastic question, a fantastic opportunity at this time in maturation of our health system. So we now have a full complement of stroke doctors, which is something to celebrate. It has taken us a long time to achieve that. They are very difficult people to train and pin down, but we now have a full complement. It's quite a dynamic complement of doctors and nurses, and they are very keen to portray their expertise further down the prevention pathway. And so they're actually now starting to actively go and seek patients with risk factors, including those who come through our emergency department. Secondly, I think this is part of the reimagination of public health, which I hope that we see in the 10-year plan. We know that there are very identifiable factors which can lead to stroke, including high blood pressure and family history. And those are the patients who we need to identify way downstream. We've started doing that with our staff health projects. And as you know, we are now both organisations running quite comprehensive staff health projects. And the team that managed that have already identified 48 individuals across both organisations who they deemed to be at stroke risk and asked to be reviewed by their GP with a view to additional measures being taken. So we're starting in-house with our staff group, but we now recognise the importance across the community.
Thank you. Sarah.
Thank you. I mean, I think Tim's addressed many of the key issues that we previously discussed around stroke, and I did have the chance to spend some time with colleagues in the stroke team fairly recently, and again, there was a lot of reassurance around measures being put in place to care for stroke patients who have to be with us at NBT in the most appropriate way, given the constraints of the fact that the numbers of people don't match with the provision that was put in place. I mean, I think it comes back to Mark's question from earlier, which is how we can ensure that people move forward through the system into somewhere more appropriate for them to receive the next phase of their care after they come out of the acute stroke unit. So again, it highlights the importance of that. And as Tim rightly said, we're beginning to think about that prevention pathway. You know, we need to think about what our roles are going forward in the discharge and how we can ensure that happens as small as possible.
And I mentioned my joint visits with the Sirona chair earlier, and one of the places we're going on our next joint visit is Sirona Stroke Services. So it would be fascinating to see exactly how that interface looks from both sides of the picture. Sue, I think you wanted to come in?
Yes, thanks, Tim. I just wanted to ask about the fractured neck of femur pathway, because it's another area where there's a stark difference between rates or the numbers of patients who access treatment, surgery specifically, within 36 hours. And this is something at UHBW we've been tracking for a long, long time, and there's been some really good work around theatre utilisation, but ultimately it comes down to accessing theatre slots. And so I suppose my challenge is, when will we start to see an improvement? Because if you look at, again, a group discussion in total difference in equity and access to theatre time, and when will we start seeing that the tide turning a bit, particularly for UHBW patients being able to access care within the 36-hour standard?
Thank you. So you've noticed that I had a particular pet interest in VT risk assessment, which I'll never stop taking the opportunity to talk about. But you're absolutely right. There are a number of these areas of quality where we do see a difference, a structural difference and a process difference. And fractured neck of femur is the other one. We know that one TNO project has been at play for a number of years, and that's been looking at these statistics quite carefully and monitoring differences, particularly at Western and the city centre. And we now have a single managed service approach, or a group clinical services, we're now refreshing that term, across trauma and looking at opportunities to make sure that the best possible practice is achieved. It probably does mean that we have to realign our theatre capacity, particularly our emergency theatre capacity across the city, and ensure that these patients are operated on as soon as possible. So it is definitely there to play for in terms of levelling up. And sorry, and I'm being rapidly reminded by my colleague to my left that the opening of the elective centre in weeks now, I would like to say, will help with that capacity significantly.
Okay, thank you. That's great. Be exciting. Exciting. Great. Anything else on the quality element of the report? So thank you for your contributions. Let's move on to finance, Neil.
Thank you. So the information provided in the report is based on the position at the end of month 2, May, at which point MBT was on plan at a 2.6 million deficit. UHBW was 1.9 million adverse to a planned 6.2 million deficit. The main issue in UHBW being a shortfall in savings delivery in April. We did close the position late yesterday, so I can update the board in terms of the month 3 financial position. So I'll just do a high level. That shows MBT remaining on plan now to 3.8 million deficit. There's a shortfall in terms of savings delivery of 1.6 million. That's largely offset by vacancies, as mentioned by Glyn a short while ago. MBT cash position is £41 million, which is ahead of plan, and division's doing well in terms of delivery, in terms of elective care, and therefore the variable payments for elective recovery funding. UHBW is now also on plan, so recovered the deficit from the first month in the year to stand at a deficit of 8.2 million at the end of the first quarter. CIP delivery, savings delivery within UHBW now also on plan at 10.6 million, although there are a number of non-recurring measures that have supported that position. UHBW also on plan in terms of cash at £69 million in the bank and achieving elective recovery targets. Just a few key themes from within the first quarter. We've touched on no criteria to reside, several points, and of course there's a financial component to that as well. The plan was to some extent reliant on a reduction in bank and agency costs associated with improving the percentage of no criteria to reside, so the deterioration obviously has an additional cost of escalation. Within the report, just again throughout earlier conversation, just to note some of the differences in approach around reporting. And between the two trusts, there are significant differences in the way that savings are reported during the course of the year. So in Q2, we will work through some recommendations in terms of alignment of that approach. Within the detail, the report shows MBT underspending against paid budgets for the year to date, whereas UHBW is overspending. This is a continuation of pressure last year, so although there's an improvement in the run rate, further progress required in order to live within the pay resource. Both trusts showing good progress in terms of reducing the costs of bank and agency in line with the plan and in line with the planned reduction on 24-25. Within the capital part of the report, just to bring out the good news within there, Sam mentioned this earlier, so a 7.5 million grant to support decarbonisation within MBT, and within UHBW, as mentioned to the board last month, a doubling in the size of the capital programme from an original plan of 48 million to now 103 million based on national support for backlog maintenance, other aspects for critical infrastructure and support in terms of elective recovery. Whilst it's a positive position at the end of Q1, across the NHS, all organisations have committed to savings plans in the region of 5 to 10%. So whilst we are at the lower end of that spectrum, we've still committed to deliver circa £40 million more than in the previous financial year. That's 40 million across the group. So clearly a significant challenge ahead in terms of the rest of the financial year. The detail in the report does show that we have been reliant on some non-recurring measures to remain on track at the end of Q1. But there's a significant piece of work to be done that we're going to base on our forecast outturn using the month 3 data in terms of some of the additional actions I believe we'll need to take to make sure that we keep on track in terms of delivering the 5%, but also take care of some of the less predicted pressures, and I use escalation costs as one example. So in the weeks ahead, we will come up with a plan in terms of the additional actions that we need to take from September onwards to ensure that we stay on track in terms of financial delivery.
Very much. Anything people would want to follow up on the finances, Roy?
Thank you, Grit. Just on the CIP, the annual so for UHBW, the annual savings plan was 53 million. After month 2, we had a bigger shortfall than we thought. Based on month 3, and he's saying the situation has improved. Does that mean for the end of the year, are we forecasting 53? Are we still forecasting 4.6 million less than that? Where do we stand at the moment in terms of being able to deliver against the CIP target?
So the forecast at the moment for UHBW is to deliver 48 million against the 53 million target. So we still have a gap of circa 5 million to resolve in order to achieve that target in full. And that will be part of the recovery plan that I go back to the board in September, is how we bridge that gap.
Got it. So with the month 3 improvement, we're still looking at 48. We've recovered back to the 48 against the 53.
Yeah, so given the fact that we are at 11 million, 10.6 million at the end of Q1, there was always a reliance on ramping up the monthly of delivery through the latter part of the financial year. And that gap of the 4.8 million was really back loaded in terms of where that shortfall would be exposed.
Thank you. Seeing any other hands raised, so thank you, Neil. So taking the whole report, it's for information assurance. I'm conscious of 2 things. One is we've been going for over 2 hours and probably need a comfort break. Secondly, we are behind time. And thirdly, our freedom to speak up colleagues are with us. Should we take literally 2 minutes and then we'll take the next item? Is that okay with you? Let's reconvene. And we will move on to our next item, which is the annual report on freedom to speak up across both trusts. And we have freedom to speak up colleagues with us, but I'm going to ask Zalia to just briefly introduce and then we'll move to you.
Thank you. Thanks, everybody. So the boards will be used to getting their own separate freedom to speak up reports on an annual or biannual basis. So I'm pleased that this is the first time we can bring the 2 reports together, and you'll see it's a work in progress where my colleagues have aligned the reports as much as they can, and that will be something that continues over time, so that board members can see freedom to speak up data side by side in a similar manner to we've been discussing a number of topics today. So I'm really pleased that we've got Kate, the Deputy Freedom to Speak Up Guardian from UHBW. We've got Hillary, who's the Lead Freedom to Speak Up Guardian at MBT, and also we're joined by Oni, who's our Associate Guardian at MBT. They'll take you through the report. Just a couple of quick things I wanted to mention. Freedom to Speak Up is one of the functions that we'll be looking at in the coming months around how we might be able to provide more effective and aligned service as a group. We have more aligned and joint services, making sure that we're providing a freedom to speak up function that is sort of consistent, and that staff in both organisations, as they start working across boundaries, will also recognise and get sort of consistent support, consistent systems, consistent training, etc. across the both organisations. Also, I think it's worth just nodding to the fact that as part of the DASH report, there's been some announcements around some changes to the National Guardian's Office, which was set up a number of years ago to provide support and an oversight to freedom to speak up across the NHS. The plan is for that office to be subsumed into NHS England and then ultimately into the Department of Health. But I think the message is quite clear, of course, that speaking up for colleagues within the NHS and freedom to speak up guardians is still something that our regulators and our patients expect to see. So that's it from me. I'll hand over to Hillary and Kate to present reports.
Thank you, Zalia. So I'm going to talk to the UHBW report first, but before I do, I just want to say thank you and acknowledge the work of Eric Sanders, who was the Freedom to Speak Up Guardian for UHBW for 7 years until he stepped down from the role on the 1st of April this year. Eric's support, his leadership, his guidance and advice
has been incredibly valuable for me, as I've worked with him in 5 years in the Freedom to Speak Up Guardian role. So thank you to Eric. I just want to provide, I'm taking the report as read, I just want to provide 2 reflections of my own on the report that you've got in front of you today. The first one is just to really highlight that the majority of concerns you'll see in the report, as per previous years, are in the category of inappropriate behaviours and attitudes and staff safety and well-being. So we're in the same place as previous years in terms of what people are coming to Freedom to Speak Up to talk about. And I'd just like to invite a bit of curiosity as to why we hear that year after year. And what I see from people who come to use the service is a lot about the context we're operating in. So the financial pressures that we're under, talking about reducing headcount, needing to make savings, and then layered on that, the single managed service working towards a group model. This is staff who are working under incredibly high pressure. And this is stressful. I don't think anyone could deny that. And that's what I hear when people come to see me. Staff are stretched. They're having to do more with less. They're missing leadership and direction in cases where they talk to me. They're missing clarity and communications about what's happening. And stress can give rise to poor behaviour. And it stops us really being able to listen to each other. And I don't think we should minimise that, because I really see that worker safety and patient safety are 2 sides of the same coin. If our workers are going to work with their heads full of distractions, stresses, they're feeling vulnerable and isolated, they are not delivering safe and effective care. And that's what I'm hearing as it comes through the surveys. The second reflection I wanted to share is around triangulation. And you'll see in the paper that we've started this year we've made some real progress in terms of our triangulation work, led by our OD and management leadership team, which is great. So we've had contributions not from just myself, but from HR colleagues, psychological services, wellbeing, EDI. And what I've seen through that is that most of or certainly a lot of the cases that come through Freedom to Speak Up are sitting in those teams that have been identified through triangulation work as struggling or in need. And for me, that was a bit of a mixture of both a bit of relief, that there are few surprises in what we hear that comes through the Freedom to Speak Up service, but also a sense of frustration that some of these services and departments have been sitting in that area of needing support for a number of years now. And we are starting to put in place structures to help that. Whether those things are the right things, whether that will stop people coming to Freedom to Speak Up from those same areas, I think time will tell. But I think underpinning all of that, if we really want to have teams in our hospitals that are thriving rather than just surviving and hanging on, I think we really need to think about what we do differently. And for me, from hearing what I hear through Freedom to Speak Up, it's what do we celebrate and value in our organisation? What do we really recognise and reward? And I think what I see is a lot of efficiencies, meeting targets, filling beds, filling shifts. And it makes me think, what are we in the business of? I think that sense of could we be losing sight of the importance of not only, of course, looking after our patients, but thinking about looking after our workers too. And I think the King's Fund says as a quote in the report that, the priorities are not just about effecting changes to structures and processes, but increasing our support for staff. And support for staff, for me, is embedded in compassionate leadership. And if we're really serious about that, I think we need to lean into compassion and compassionate leadership and what that means. And what that means to me is completes that speaking up circle. So we're not just talking about speaking up, we're talking about listening up and following up. And if we're doing that, then I think, we're in a place where people will feel seen and heard in the organisation. And I suppose, as stated in the front of the paper, before I pass on to Hilary, my question is, what can we do as collectively to support it? What do we want to role model and what do we want to celebrate? Thank you. Hilary.
Thank you, Kate. And so Hilary, lead Freedom to Speak Up Guardian for MBT, and I will speak to the MBT report. But I'll just reflect on hopefully you will have read the report and seen some of the commonalities between the two reports already, to the length that when Kate and I were talking about actually what we were going to say, we could have almost have spoken with one voice, and we almost joked about doing that. So I will probably be saying very similar messages to Kate in a slightly different way, but absolutely would back up what Kate has already said. So hopefully you will see some of the commonalities in the data, the numbers, the themes that are coming across, and the alignment of our key messages to you as the board as well. So we at MBT have had the similar number of concerns and overall themes from the year before. The themes haven't changed hugely. There was a slight increase at MBT in the number of concerns that would fall and or had elements of patient safety or quality of care in that. And you will be able to see in one of the slides how that breaks down into slightly different themes. The overall themes that we also see through the MBT triangulation group, which I think has been going now about 18 months, 2 years. So when we align the themes through Freedom to Speak Up with our partner groups at Triangulation Group, so lots of similarities, and it's about similarly how are the organisations going to shift those themes on. We are still trying to find the sweet spot, I think, between around that triangulation group, how that works well, how we look at teens in trouble, hotspots and themes, and have some assurance around actions that are going to resolve those issues. So I'd invite you to stay curious around those themes, consider what perhaps you're hearing through various committees. Ultimately, similarly, a lot is around interactions, relationships, communication, ultimately people feeling safe to speak up and bring their views to bear. So that really is about supporting the group vision around delivering safe and high quality care, supporting our people to thrive within that, develop, feel empowered and engaged, and making the most of our resources through efficient and effective working. It aligns with our patient first work. How are we going to hear the voices of those who are doing the work and can really improve the work and aid efficiency? The staff, so when we're talking about triangulation, staff survey results, you will see in the slide pack are kind of similar for MBT and I think probably for UHBW as the year before as well. Underneath those headlines, there are areas of negative variance or red rag areas. We have sent information through to the divisions to be considering what those results mean, what they need to take action on in their particular spheres. And aligned with that, there's been a couple of good examples where issues raised through Freedom to Speak Up have also aligned with the responses through the staff survey results. And the divisions have taken that information, used it to have further dialogue with managers and staff, held listening events, met with staff individually if they didn't feel safe within those listening events, to really consider maybe what the short-term and the longer-term actions are that they can be taken and how they can keep having a dialogue within those areas. Those are really good examples that we'd probably like to see more of, if we're honest. So we'd also like to invite you to consider how you as board can actively support our work as the Freedom to Speak Up network, so as the Guardians and also our Freedom to Speak Up champion networks as well. So you will hopefully have got from the reports that we do a lot of proactive work alongside the responsive work, and that is how we are helping support the normalised speaking up environment so that people feel they can just raise an issue or an idea or a safety concern or risk any day, every day to their managers, and that be heard well, actually listened to with some dialogue, responded to well, and some action taken, some learning highlighted, and that be disseminated. This is all about that improvement cycle. So Freedom to Speak Up adds an additional route to come to, but also very much as a neutral space. We can offer some time to really understand people's concerns, but also be that connector and facilitator of information flow. But ideally, obviously, we would prefer not to be needed. So we always talk, I think, with both organisations about ultimately wanting to be that safety valve. So the more we can get to normalising this environment, then that information is a direct flow that can be taken advantage of, again, efficiently and effectively. So I'm nearly coming to a close now. So we are planning to support our managers to be able to listen up well and respond well. And obviously there are more and more pressures for everybody, including as board members. And again, wanted to reiterate what Kate has already said. We are working in a pressured environment anyway. There's even more pressures now, and I think people are reflecting more at MBT as well, feeling those pressures, the financial pressures. And it's at those times that people will potentially not speak up, and then the organisation is at a place of potential risk, of unsafe practice, people doing workarounds, adaptations, and people may not be able to send those early warning signals for concern of their own position. We've noted in the report that it's 10 years on from the Sir Robert Francis review, and elements within that included focus on finance and a tendency to lead to kind of everyone being stressed, pressured, the tough culture, workers feeling less able to speak up and feeling psychologically safe. So perhaps the best way for us to be able to more safely predict the future is to create that together. So I think that's our invitation to sort of have your support in building this healthy, wider speaking up environment where there is action taken for safety, efficiency, effectiveness and belonging. So our people are key to this, and the group actually operating in an efficient and effective way. That needs inclusion and belonging. Productivity needs well-being and mutual support, and we don't want more people reaching burnout. And ultimately, all our workers are here to serve our communities. So I want to ask, I don't want to put words in Kate's mouth, how each of you will role model and encourage this environment of speaking up, listening up and following up, how you will communicate buy-in across the group, showing proactive listening, closing of loops is really important, communication of learning, adding value, and reducing feelings of futility or fear so we don't risk losing vital information. And asking how each of you can make impact in this area to support this work. Thank you very much. And I think we'd invite any questions, comments.
Okay, thank you. So, come to Arabelle in a moment, and I know Sean also, and Mark, which is going to completely defeat what I was just about to say, which is, you've asked some really open questions here. And realistically, we're not going to have the quality of discussion. We were in this space last year with UHBW, actually, and it resulted in a whole day board development session on freedom to speak up and triangulation and all of those things. So realistically, I think we're going to have to find a different space to have that quality conversation, because the nature of the questions you've asked, I don't think we're going to do justice to. But I'll take the 3 points that have been made, the 3 hands that have got. Oh, Sean, you're withdrawing your
holding my hand in it. That's exactly
what you were going to say anyway.
I was going to say, I mean, that was all great. It felt like it was left hanging, and it also felt as in we need to do that next action. But I also felt maybe I missed it, and apologies if it is, you mentioned the valve in a system, but we're not doing enough to take the steam out of the system in the first place, to take that pressure. And it just feels like we need to think more laterally about it as well. You know, the strong thing there was the stress, everyday stresses and strains, and then people come to work and it's there again. It's a rhetorical question for here, but I want to take away, are we doing enough to take that pressure away at the beginning? Not wait until there when we're encouraging people to speak up and have problems. get to the root cause. And I think that's where we need to be when we do the day thing or whatever it is we do as the next step. I think it's key. But thank you both. That's brilliant.
Okay, now I've seen Kelly's hand go up as well, and I can see Linda twitching, and I feel the development centre session coming on as I speak. But let's just, if we can be really brief, folks, because it is 12:30. We're supposed to have finished the meeting. We've got about 5 items to go. So, Arabelle.
I'll keep it really short. I thought it was really powerful how you chose to present those reports, and so I thank you for that, because I think it was also quite interesting coming straight after we'd been through the performance report, where of course we're talking about all the numbers and all the things we have to do, and it just really brings to light the constant pressure that we're putting on staff. I mean, my main point actually was going to be about that board day that we had, and actually that I think that's something we need to do regularly, because we know that freedom to speak up isn't the only route for speaking up. And actually, when we look at everything holistically, we just start to see other things that we might not see just with the pieces that you've talked about. I do think it's good that we're using the triangulation now to get proactive on the areas that we know are struggling. And I think that's been a real development actually over the last few years. So I encourage that. And the question I was going to ask, but don't answer it, I'll just leave it out there hanging. We've invested at UHBW a lot of work in the sort of compassionate leadership training, really to try and address a lot of this stuff, to build that leadership and management capability. So maybe something to just reflect on is, do we think that that's having the impact that we wanted it to, because it was a big investment for the trust, and I would hope that we're starting to see some improvements from it.
Very quickly, I thought it was a really powerful report, and the spoken word that went with it from both of you, I think, enhanced it as well. So thank you for that bravery and sharing that today. I think that's worth saying. I was going to mention about triangulation across minority groups and the kind of intersectionality. Obviously we can't, and numbers maybe are too small to do anything there, but if it's anything like other large organizations where you see clusterings around minoritized groups, and that can be against any protected characteristic, I think it's really important to actually, even if it's a small bit of narrative, just to sort of say that we've got divisions, and it's great to see students come from there as well, because they are your future workforce, but something around the intersectionality with protected characteristics as well. I know it's not easy, but otherwise I thought it was a really powerful report, and well done for presenting it in a really powerful way.
Thank you. And I know that's something we have been discussing, isn't it, about bringing that data? Yeah.
Okay, and Kelly.
My challenge was actually going to be to the executives around the time of closure, because I think people will speak up, as we said, when they see action being taken and that it's an effective process. And I think in the context where I know in MBT, in terms of the appraising numbers that we've got, that it is exceptional that the numbers that we have on appraisals. I've never seen anything like it in any organisation. And to think that we can achieve that when we really focus on it, I think if we had that same focus on closing freedom to speak up cases and really drove that message with the teams, I think that would really, my challenge would be, would that move the dial? Mm.
So you've spoken really passionately and convincingly, if I can put it that way, about the importance of culture, about the importance of psychological safety. Civility saves lives. It does connect with safety and the experience of the people we serve as well. So it really, really matters. I know I speak for the whole board in saying that we very much support the work you're doing. Our two NED champions, I know, who spent time with each of you, and I did a walkabout just recently with both Kelly and Ollie, and it was great to see the work that you're doing and the visibility that you have across the trust. So thank you. Xavier, can I ask that we take some time out of the meeting to work out what we do with some of these questions that are being put to the board, in the light of the fact that we're coming together, well, we have come together as a group, and therefore we're going to be looking afresh at the way that we approach freedom to speak up across both.
Plan. It's always our intention to have a people and triangulation focused development day, of which freedom to speak up will be a part of it. So that is absolutely the intention.
Okay, fantastic. So I hope you'll take assurance in that. We haven't forgotten you. We will come back to this shortly. And thank you very much for your time and for the work that you, all three of you, do. Really appreciate it. Thank you. Hey. We're going to move on to the upward reports from the various committees now, and starting with the report from, I think, our very first digital committee in common across the two trusts. So, Roy, over to you.
Thank you, Ingrid. I'll keep it brief and take the paper as read. Yes, indeed, we had the first of our joint digital committee meetings at the end of May, which I think the committee members were very excited about because we were looking forward to this for a long time. It helped that we had a joint CDI in post for a while, so I think it was a very productive meeting. There are certainly things that we've been working through in terms of how does the committee interface and interact with the other committees, for example, finance, and of course then be a process of norming and forming before performing. Just a few things to highlight, and we went through sort of the standard operational performance. A brief update is in the paper already, where we also, I think the committee highlighted, instead of looking at what's just happened and what's about to happen, it would also be helpful to have a sort of a longer term post review. So CMM is an example that we spoke about, where CMM is being implemented. The benefits that we want to see from CMM at a time in the future, we do need to look back, would be 12, 18 months from now, to see has a digital project delivered the benefits that we wanted it to deliver when the business case was approved. Just a quick point on information governance and compliance. We had an external audit regarding our data quality and data security, and both trusts came out with flying colours, really strong report on our IP&C. And last point on AI policy, we went through a hospital group AI policy. As you know, as a group, we want to. We know workers, staff are using, knowledge workers are using AI. We want to support it. We want to have the right constraints and the guardrails to support the safe and consistent use of AI. So we've made a good start on that. I'll leave it there, or happy to take questions.
Thank you. Anything to add, Neil, from your perspective?
I mean, I think the AI policy work is really important, you know, with a very strong ambition to support innovation and all of the benefits that come from using automation, but to do it in a way that is safe and supported and protects our confidentiality where that's important. So it's really helpful to have that oversight and to do it at group level. So I thought that was a really great step that we took.
Rosie.
Thanks, Roy. Can I just ask a quick question? I mean, given the 10-year plan this week, and also given this will be a key enabler, the digital transformation to the joint clinical strategy, is the committee confident that the pace is fast enough on this work to be in, so it doesn't become a barrier to the kind of work that needs to happen and underpin everything else that's going on around the joint clinical strategy?
And from my perspective, I think certainly the UHBW board, we have already, we've always spoken about the pace and of digital adoption, and then we want to move faster. And there's always been that balance of, right, do we have the funding to be able to implement the programs that will speed this up. I think the sort of 10-year plan in terms of analog to digital, I don't think that's been a surprise. From a committee point of view, this is clearly the journey that we'd want to been on. If anything, it hopefully will support and bolster sort of the journey that we're on already.
Good. Just respond in addition to Roy's comments and say that I think one of the opportunities that we have to consider is how we align our ambition with our capacity to deliver that ambition. And I think in this particular instance, looking at the shifts, the move to community, the consolidation, a potential aligning of services with a clinical strategy, and all of those elements, we have to be careful about the consideration of doing all that work and the pace at which we wish to do it, and then align that with our ambition, and then get the digital committee to make sure that we are considering the resources to deliver the capacity to undertake that work, and make sure we're aligned that the two things is larger.
Great. Well, given the crucial importance of this, it was there all along anyway, but even more so with the 10-year plan. Really great to know that we've got this now complete focus in the committee. So appreciate the work you're doing to get that off the ground. Thank you. Let's move to Quality Committee for MBT, of which there have been 2 meetings, Sarah.
Thank you, and I'm grateful to Sean who chaired first of those 2 meetings. I just wanted to highlight that those 2 meetings between them received the safeguarding report, the quality account for MBT, and the Organ Donation Committee annual reports, all of which were previously have come to board, and the committee was content with those reports on behalf of the Trust Board.
Thank you very much. Anything people want to pick up from there? Okay, thank you. And Sue, UHBW.
Thank you. So 2 meetings, one in May and June. You've got the papers there. So I'm not going to go through the performance issues because we've talked about them, no criteria to reside, VCE, fracture neck femur, etc. One thing from the May meeting, I think it's important we have an update on the new provider for translating and interpreting service. And if those from UHBW knew the service before, this is such a massive, massive improvement. And I think everybody at the meeting we were so impressed in terms of the service provided and the access. So, it was a brilliant presentation. In the June meeting, again, there's just a few things to make the board aware of. One, which is the proposal for the clinical genetics service. This is something we've been monitoring for a while. It's a fragile service, and it's now a proposal to move to a single Southwest genetics service hosted by Royal Devon University Hospital. And we received a paper, and we were assured that the risks currently experienced by the UHBW service would be addressed. And we understand that paper will be coming to the board to formalise that process. And then 2 key actions, decisions. One about approving the quality account for 25-26, and also the committee approved the closure of 4 actions on the CQC action plan, leaving 7 due actions.
Thank you very much, Sue. Anything to Sue? Okay, so all of those are for information. Register of Seals, Mark.
Yes, nothing much to add really to the report. Ingrid, just to note that there's been 2 uses of the seal at MBT since January and 8 uses of the seal at UHBW since the last report in May. So it's just here for the board to note.
Okay, duly noted. Thank you very much. And Xavier, over to you for the Constitution and Standing Orders.
Thank you. So hopefully this is pretty non-controversial. We approved some new standing orders and constitution for 2 organisations earlier in the financial year. This is just an update to some definitions to include the concept of jointly appointed group executives, jointly appointed group NEDs in due course, and also to clarify that the hospital managing directors no longer line manage the executive teams at the 2 respective trusts, but manage their hospital management crews instead. So it's just the next logical progression of ensuring our governance documents reflect reality.
And if anyone is insomniac, we have the entire thing in the reading room if you want to look at the track tables. So they are there.
Make one point on there. We were using the naming convention of trust management team rather than hospital management team. And in the SFIs, it's there as hospital management group.
We'll make that consistency change. Thank you. Mark did pick up on that.
Okay, yeah. Yes, thank you. Okay, so is that approved then? Okay, thank you very much. Any other business, anyone? Will we break? Okay, in which case, thank you very much. We will reconvene the private board in due course at 1:30.
Well, it was 1:15.
1:15. Should we make it still 1:15? Happy with that? Half an hour break. Brilliant. Okay, thank you.